everyone to Cancer Convos with Grace B. This is your host, Grace B, coming to you from New York City, the city that never sleeps and is home to Cancer Convos with Grace B. As you all know, until there's a cure, prevention is the cure. So make sure to do your medical checks always, okay? So in this episode, which is titled Breast Reconstruction, a plastic surgeon's perspective, to have plastic surgery especially is an important decision. And so selecting a board certified plastic surgeon is of the greatest essence. It is why in this episode, I am delighted to host my esteemed guest and board certified plastic surgeon, breast reconstruction surgeon, and microsurgeon. He is also the president of PRMA Plastic Surgery in San Antonio, Texas. Under his leadership, PRMA has become one of the busiest breast reconstruction practices in the world and caters to several patients from across the globe. So, without much ado, I am going to be welcoming Dr. Minna Krispolu to the show, fondly called Dr. C. Thank you so much, Dr. C, for coming on.
Oh, thanks so much for having me. Great to see you.
Lovely to have you too, and great to see you. So let's dive straight into the show because I know you have a busy schedule. Please let the audience know a bit about you and your reason for actually choosing this area of specialization.
Well, I've wanted to be a plastic surgeon ever since I was 16. I have no idea why, really, what clicked, but it all started really watching history shows with my dad. My dad was a huge history buff, and he loved any history documentary, particularly when it came to anything that was military and based on wars. And so that was actually my first exposure to plastic surgery, was seeing documentaries about reconstruction after trauma during the world wars. And then the more I got into it, the different types of reconstruction, the breast reconstruction really kind of took center stage for me. But yeah, it all started with watching the History Channel with my dad. Yeah, so
awesome.
And then
it's brought you a long way.
Well, and then you're very, it's life's based on so much on luck, isn't it? And I've been very, very lucky to come across really some huge individuals in the field of plastic surgery, in terms of accomplishment. And you need some luck, and they see something in you that you didn't realize you had, or for whatever reason they take you under their wing and kind of propel you. And I've been very, very lucky and had those relationships. So I'm really, really very thankful.
Wonderful. You yourself didn't know that you had those inherent qualities that were so glaring for people to reach out to you and, bring you under their wings and propel you forward. So it's a good thing,
It's been a massive blessing just being able to be part of and help build a team that's comprised of so many people sharing the same passion, in terms of pushing outcomes forward to be the best that we can be, provide the best service and best results for our patients who so desperately need help during that moment in their lives. So, you mentioned that we're the biggest or busiest practice, breast reconstruction practice in the world. Well, that doesn't happen as a solo practice. That you can't even begin to think that way unless you have the right team. So we're extremely lucky here in San Antonio. PRMA. We've just hired our 9th surgeon actually. Who'll be starting later this year. So can't wait. So, and that's a really big point, I think, that your listeners need to take on board, and that is anyone interested in breast reconstruction, really it's all about the team and not so much about the individual surgeon. So, and I say that not just for plastic surgery, but for breast surgery too, because anyone who's looking at breast cancer surgery or risk reduction surgery, because they're a gene carrier or something, or strong family history, it's a really good idea to look at your team of surgeons that you're considering. Does your breast surgeon do a lot of breast cancer surgery? Does your breast surgeon work with specific plastic surgeons? Don't just go and pick surgeons on an individual basis, because the relationships that they have impact your outcome. You want people who work together all the time, that have an understanding, that do a lot of breast cancer work. So it's never about, it should never be about the individual. It's always about the team. So
absolutely. You took that right out of my mouth, because that is something that I would ask you to expatiate as we're going forward. Teams, But in the
absolutely.
meantime, who is considered, what is breast reconstruction?
The concept is basically recreating a physical breast, right? And so most women are candidates. So there are different stages of cancer, as you know. Most women who have early stage cancer, stage 1, stage 2, are going to be candidates, unless they've got significant, other health issues that don't make them a good candidate for an anesthetic or something. Your other medical problems always need to be tuned up if you're going to have any surgery, and breast reconstruction is no different. So if you're diabetic, you want to make sure your diabetes is under control. If you're overweight and you've got time to kind of focus on your nutrition and get in better shape in that regard, sometimes you don't have the time, but it's all about tuning yourself up as much as possible. If you've got high blood pressure, you've got to get that under control, those sorts of things. And so it's very important to have a team. Again, there you go, team, to help you with those things. Even if you have more advanced cancer, like a stage 3 or even stage 4, you can still be a candidate for breast reconstruction depending on your situation. And then it becomes more about timing for stage 3. And then for stage 4, which is metastatic disease, we used to say that if you had metastasis, in other words, cancer in another part of your body that had spread outside the breast or lymph nodes, beyond that, that wasn't a person that really should be considered for breast reconstruction. We now know that really was wrong.
Okay.
And if you have stable disease, even a patient with stage 4 can be a candidate for breast reconstruction. We used to actually think that someone with stage 4 wasn't a good candidate for breast cancer surgeries, for a lumpectomy or a mastectomy. But there's data now to show that there's actually some benefit in removing the primary tumor, even in someone whose cancer has spread beyond the breast and lymph nodes. So things are constantly evolving in the field. But long story short, if you think breast reconstruction is something that you want to do and consider, then presume you're a candidate and go and get a consult. Find someone who does this all the time and go and visit with them and check out your options. It's the only way you're going to know. Don't presume you're not a candidate, because most people are these days.
Okay. I was just going to interject when you were talking about women. Would men also be good candidates for this? Because, of course, we now know that men do have breast cancer.
Yeah, absolutely. So male breast cancer still has, there's still a ton of taboo, stigma, difficult to talk about. it's when it comes to breast cancer, there is, there's an element of sexism, right? Because a lot of physicians don't. I mean, in their defense, many physicians don't even know that breast reconstruction is an option for men in terms of techniques that are available. But even amongst physicians, there's an element of, oh, well, it's a dude. He's going to think a scar is cool. He doesn't care. He doesn't have a breast, and that's very unfair. I've had calls from medical oncologists in the region, and they're almost apologetic for calling me because they've got a gentleman in their office, and it's, he's asking for breast reconstruction. And they're almost apologetic for wasting my time, because of course that's not a good idea. And so every one of those conversations ends up being an opportunity for education. But again, and for men, obviously it is a different process, and some men may not even want their breast reconstructed because the contour may not be that different to the other side, and maybe they just want a nipple reconstructed. Maybe they just want a nipple areola tattoo to give the appearance of a nipple. Maybe they want a decorative tattoo to cover up the scars. Maybe they want fat injections just to give them a little bit more volume to match the other breast. Maybe they even need an implant because that's what they need on the other side, to match the other side. And this can be a custom implant. But there are multiple options. I'm glad you brought that up. Men absolutely get breast cancer. It's not chest cancer, it's breast cancer, because men have breast tissue. And that's part of the stigma. We got to call it what it is.
Yes.
Yeah, thanks for bringing that up. Absolutely. They also have options, always.
Yeah. Many men really don't know that they have these options. So it's actually good to share the word, spread the word.
Yeah, and there's no really, it's hard to find a better example of self-advocacy, right? Patient advocacy, because when you're dealing with a situation where not all physicians know about these options, then if you don't advocate for yourself and do your research, the chances are you'll never find out, because you just they won't be offered. It's not malicious, it's just
the way it is.
Just the way it is. And not, doctors are human, and we don't all know everything about everything, right? That's unrealistic.
Yeah. Absolutely. So in breast reconstruction, what are the common procedures?
So there are generally two types, implants and your own tissue. And so implants is the most common way. Using an implant is the most common way to reconstruct the breast. It can be done at the same, the implant, the final implant can be put in at the same time as the mastectomy. So you have like a one-stage kind of reconstruction. That can be a good option in certain situations. The vast majority of implant reconstructions are still done in a staged way. And by that, I mean you get a temporary implant first. That's called an expander. And that can be used to further expand the tissues and help shape the breast a little bit more. And then this expander is later replaced for the final implant. And you can put the implant under the muscle, on top of the muscle. You can combine this with fat injections or fat grafting or lipofilling. That's basically liposuction.
Yes.
Take the fat and inject it under the skin, helps you camouflage the implant some more, provide more padding. So implants are whether it's a one stage, which is becoming more and more popular, or more of a traditional two-stage, women need to understand that the vast majority of times, this is not going to give you the same result as a cosmetic augmentation or a boob job. Okay, so what we see all the time is patients with breast cancer considering implants, and then they're friends, and a lot of them have had breast implants, cosmetic augmentation, and they're coming from a position of love and support, and they say things like, oh, now you can have the boob job you always wanted. That's actually quite a damaging thing to say, because in most situations, this is nothing like a boob job. So I do have patients that look like they've had a cosmetic breast augmentation, but that is a very small percentage of women who get implant reconstruction. Okay, so that's a home run, and that's not the norm. So those are the results you put up at a conference to make yourself look really, really good. And most surgeons can probably only count them on two hands, right? So you can get a very, very nice reconstruction with an implant, but women must know it's not like a cosmetic breast augmentation. Because even if you're small breasted, you still have you're still going to have more breast tissue than a mastectomy patient is left with, right? A mastectomy patient, obviously, a mastectomy removes the breast tissue, not all of it, but over 90%, you still have some breast cells left. But the typical mastectomy patient is left with skin, if they're having a skin sparing mastectomy. Maybe they had a nipple sparing mastectomy, but all the filling of the breast gland is gone, and they have a little bit of fat left under the skin. Compared to a breast augmentation patient who, even if they're small breasted, and that's why they're having the procedure, they're going to have a lot more padding available to cover and camouflage the implant. So that's the number one technique used probably around the world, not just this country, for reconstruction is an implant. The other group of procedures is tissue or flap options. That basically means taking a piece of tissue from part of your body and moving it to the chest to replace the breast tissue that was removed. And there are different ways in which that tissue can be moved. There are ways that involve microsurgery. That's what we specialize in, and that involves removing the tissue, basically like a transplant. The tissue is disconnected from the body, and this can be from the lower belly, or from the thighs, or from the buttock area. So there are lots of different flap options. These pieces of tissue, they're called flaps. So we have lots of options depending on the patient's body habitus, where they have the tissue to give. And that tissue is disconnected from that part of the body. Yeah, that donor site, that's called the donor site. Along with its blood supply. And then that's transplanted to the chest, and the blood vessels are connected to blood vessels in the chest. So blood flows in and out of this new natural breast. So not all plastic surgeons do those procedures. That's why you need to find a microsurgeon to do those tissue transplantation flaps, those microsurgical flaps. Another way to move tissue is to keep it connected, but if you keep tissue connected to the body, and the reason to keep it connected is typically the tissue remains connected to the blood supply through muscle. So for example, the latissimus on the back, that muscle and the overlying fat can be disconnected, but the muscle remains attached in the armpit area, and then that tissue is rotated through the armpit, and the blood supply comes through the muscle that's still connected in the armpit area. Or a tram flap. A tram flap is probably actually the most common procedure. This is a pedicled flap. So this is a non-microsurgical flap where you take the lower belly tissue along with the six-pack muscle, the rectus muscle, because the blood supply comes through it, and it's tunneled under the skin up into the chest. The problem is you sacrifice muscle. So that's why these microsurgical procedures, especially the really advanced ones that we're talking about, they are very important for patients to know about, because it preserves the patient's muscle. And so it minimizes complications. So for example, if you do a tram flap, you have a much higher risk of a belly hernia compared to a DIEP flap that spares all the muscle.
Mm-hmm.
Lots of women in America have both breasts operated on. A lot of women who are choosing mastectomies are choosing to remove the healthy breast too. That's a whole other podcast, because that's a major issue.
Oh,
in,
definitely, you're coming back, Dr. C.
Yeah, that's a major issue in the US more than any other country in the world. We do a lot of mastectomies on healthy breasts because women are very anxious about developing breast cancer in the future. And so, the vast majority of the time, that's not a decision that's based on data or evidence-based medicine. It's a decision that's based on rational fear. Okay, anyone who has cancer once, their fear of future cancer is very rational, right? So, but that's a phenomenon that's particularly kind of prevalent in the US. But anyway, so particularly in a situation where you're having both breasts reconstructed, if you're doing tram flaps for both, now, as I mentioned, you sacrifice the muscle for the pedicle tram flap. Now you're sacrificing both of your sit-up muscles because you're reconstructing both breasts. And now this lady can't do a sit-up. She can't get out of bed. Plus, because you're removing all the muscle in the belly, you have a much, much higher risk of ongoing issues with your abdominal wall, like a hernia or bulging. So saving muscle is always good. It preserves function and decreases complications. So lots of different flap options. The most common one is the DIEP flap. That's actually the procedure that most people travel to PRMA for. We do other flaps too, obviously, but that's the one that we're really known for multiple reasons. We're reconstructing nerves to provide sensation back to the breast, because as most of your listeners probably know, or at least I hope they know, or they should know, a mastectomy typically leaves a patient with a significant change in feeling, with significant loss of their breast feeling, and some women are completely numb. And that's actually pretty common to be completely numb after a mastectomy. So we do a lot of nerve preserving mastectomies to help maintain feeling. And when we can't preserve the nerves in the breast during a mastectomy, we do our best to reconstruct the nerves to provide some feeling. That's very important, even though it's not always like Mother Nature provided, or rarely like Mother Nature provided. Even being able to feel a hug or a touch, and certainly being able to prevent injury from something hot, because you got to be able to feel if something is hot, otherwise you can burn the skin. So we see women who have been reconstructed at other facilities, and then they were told to put a warm compress or something by a friend or something. Maybe their breast was achy or something. They put a warm compress on, except it wasn't warm, it was hot. And now they've got no feeling. They have a full thickness skin burn to their breast. And if they got an implant reconstruction, now the implant is exposed because they've burnt a hole in the skin. So being able to feel is very important. And way beyond, or way before rather, we get to talking about erogenous sensation and sex and all those things. I mean, skin protection, the protection is a function of your skin well before we get to the erogenous benefits, right? So long-winded answer to the types of reconstruction, but all of these all of this plays in, and and you can get, and I know we're a tissue, we specialize in microsurgery and all that, but patients need to know you can get a very good reconstruction pretty much with any technique. It's all about matching your options with what you want, right? So, I mean, we've had discussions before about shared decision making, right? So what's good for one person isn't necessarily good for another. So the D flap, for example, has been is often referred to as the gold standard in reconstruction, and I think it is, right? It's tissue, it's warm, it's soft, it's you, it won't rupture, it won't leak. You can
Yes.
you
And
know,
you
you
won't have
can
any adverse
restore
effects.
feeling.
It's your
Yeah, all those things,
tissue.
you know, but it doesn't mean that everyone must get a deep flap. For some women, implants are the best option, right? For some women, no reconstruction is the best option. Aesthetic flat closure is the best option, right? So ultimately, you know, when I'm asked what's the best reconstruction, I mean, I actually don't care. I don't care, because it doesn't matter for that individual person. It doesn't actually matter what they get in terms of the procedure. What matters is that if it jives with what they want and what they need for a successful outcome. So whether that's aesthetic flat closure, implant reconstruction, a flap or a deep flap or a thigh flap of some sort, it doesn't matter. It's all about researching your options and finding what the best option is for you. And then,
Wonderful.
yeah,
Honestly.
and then the other option for reconstruction in terms of tissue is fat injections, which I know I've already briefly mentioned. We typically use fat more like an adjunct to kind of tweak and improve other types of reconstruction. You can do fat grafting or fat injections with an implant. You can do fat injections with a tissue reconstruction with a flap to fill in contour issues after a mastectomy or add a little bit more volume. But you can also reconstruct an entire breast just with fat grafting. That's typically multiple procedures. It's typically more procedures than any other technique in most surgeons' hands. But that's another option also.
Before I forget, that fat injection, is it something that has to be recurring all the time?
No, not all the time. It's something that typically has to be repeated, because between 30% and 50% of what you inject gets reabsorbed.
Yes.
So it's very uncommon to be done in one go, in one surgery. Anyone who's getting fat injections needs to be prepared for multiple surgeries. But having said that, most women, regardless of technique of reconstruction, most women need to be prepared for more than one surgery anyway for the best results. It's just, if you're going to reconstruct an entire breast with fat grafting, especially if you want a fuller cup, you're going to need more surgeries. So,
Dr. C, there's something occurred to me. Now, we have been talking about women that just had the mastectomy, right? And, you know, either having it simultaneously after the mastectomy, I mean, the breast reconstruction, or sometime after. What about for those who have had radiation, for example, and where you have the burn and everything is dry and flat, and then after a while they now say, oh heck, I don't like this, I want to have some kind of breast reconstruction. What would you say to that?